Yeah, we can see it.
All right, great. Okay, well, welcome everybody. We'll go ahead and get started, and we'll go as long as my voice holds up. My whole family has gotten affected by this Omicron, so I'm now convalescing after a couple of really hard nights over the weekend. And for the most part, I think I'm back. Just my voice continues to kind of struggle, which is sometimes going to be challenging. But I just wanted to share a lot of updates because it's been such a busy week. I hope all of you are trying to stay well hydrated, well nourished, and healthy as much as possible. This variant is working its way through our ranks, I'm sad to say. And so I know that many of you have relatives and family members affected, in addition to your staff and colleagues. And I definitely want to send my wishes for good health to everyone. This is, even though I was fortunate enough that the boosters protected me from having to go in to get any special therapy or anything. This is a very challenging infection, even for those that are outpatients and mild in their category. So I definitely empathize for everyone who's been infected. Anyway, let me share my screen and just share updates from the health department. And then I think we'll have time for Q&A also. In terms of what's going on, it's kind of interesting. I'm going to share metrics from the statewide perspective and then talk about Fresno. San Francisco, it kind of looks like there are effective. In the Bay Area in general, there are effective has now come down below 1. And so now what you're going to be hearing is that perhaps they are peaking right now and that they are going to slow down their case transmissions. It turns out that their hospitalizations will continue to rise until probably until the end of the month is what these CalCat estimates are showing. And here you see San Francisco's hospitalizations as well as ICU numbers. They're going to continue to go up. LA, same thing. In fact, it's probably going to peak a little bit later from the best information that we have, which is the first week of February. And so I just wanted to share that, different parts of the state are projected to peak at different times. And then here's the Fresno numbers. And what we're going to do most likely is continue to add hospitalizations and ICU numbers through early February. Right now, we're at just above 500 admitted cases, and that will probably go into 7 to 800 range. Remember last week I said that it may go into the 1,200 range. So keep this in mind that these numbers kind of, they fluctuate because these are predictions and they're trying to recalibrate their predictions based on what's actually happening on the ground. But right now, this is the prediction is that the numbers will continue to rise and that we're probably going to get into the 7 to 800 range for total number of ICU beds, which is not good news because things are already so impacted at all of our hospitals. We're going to talk more about the kinds of surge response that we're trying to support in a little bit. But we basically are in for several more weeks. I would say at least 3 more weeks of real intense increases, and then either a plateauing or hopefully some sort of an abatement of that in the next few weeks. This is just another way to kind of carve up the modeling here. There's different curves here, as you can see, and I know that this is a lot of lines and colors. What they've done here is they said, well, if everybody uses masks and if everybody's vaccinated, or what if they don't, and then what if this variant is more transmissible versus less. So there's different projections that are basically just, on the same graph, which is why there's so many different curves. The reason that I want to share this is just to say, look, none of these scenarios show that there's a peak that's already happened. The peak is still in the future, and all of them kind of line up at the end of the month going into February. So even though they will be on the downslope, February will still feel extremely challenging because we won't be back down to normal or pre-surge levels probably until mid to late February at the earliest. So I know this is a very confusing graph, but I just wanted to share that we're still on the upslope of the tsunami, no matter how you slice and dice the modeling predictions. Here's numbers that the state shared, and I kind of trust these a little bit more because their epidemiologists just seem like they're on it. And this is they're dividing it up by region. And these are two different colors that represent two different modeling assumptions, but I kind of interpret this in a little bit different way. But let me share the different regions and what they're doing. So you can see the black dots are what's actually already happening in terms of number of cases. And guess what? The Bay Area has peaked and started to come down. Greater Sacramento has peaked and started to come down. Southern California has peaked and started to come down. San Joaquin Valley still on the way up. So that's why I say we're going to be a little bit behind other areas of the state, which is going to be irritating as hell, I'll tell you, because they'll start declaring victory and saying that, oh, they're through the surge, blah, 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 and we'll still have a lot of cases that we're adding. That's exactly what happened with the Delta surge, but that's we can just already see that happening. Anyway, what we also see here is this green curve. And to me, this green curve really represents what the hospitalizations will probably look like, which is that they will follow and trail the number of new cases that we add. And again, you know, if you look at the San Joaquin Valley and the green curve, you can sort of see that this puts us that you know, February and the first week of February will probably be when we peak and then start to come down is what our best predictions right now are. Okay, and lastly, and then I'll open it up for questions. A lot of you have asked me really good questions about, you know, what's the data about boosters and vaccinations? And to me, this really tells the great story is that, you know, when you look at the case rates and the hospitalizations, solid lines are non-vaccinated people. Dashed lines are vaccinated people, and boosters, dotted lines are boosters. So here you see the solid line like is way magnitudes higher than the vaccinated, and the boosters are super low. It's a magnitude lower. And that's why we say the boosters are protective. They're definitely protective against hospitalization. But even that is going up a little bit. And that's to be expected, knowing that, you know, we do have vulnerable individuals that are boosted, maybe immunocompromised or have other comorbidities, et cetera, that then land them in the hospital. And so that's why the boosters are still very highly recommended. And I think this really shares that the vast majority of cases that are landing in the hospital are non-vaccinated. So please share that with your staff who are telling you that the boosters aren't working or that the boosters don't work. The boosters are definitely keeping people out of the hospital. And that's what we need to share with everybody that we can. Here's an MMWR that dropped yesterday. They actually looked at California and New York data during the time of Delta, and they found some interesting findings, but really the graph again tells the whole story. So I'll just go to the graph, and this is basically linked for you in the top of this page. And there's a lot of headlines about this right now. I think the headlines are misrepresenting what's going on, but let's just see what the graph first says. So this is basically the Delta surge as New York and California experienced it last August. And again, the solid line is the non-vaccinated, non-infected people. And that was really the bulk of who got the infections. Then you have all these little dots and dashes along the bottom. And those happen to be people that were vaccinated, which is the dashes, or they basically were unvaccinated, but they had a prior infection before Delta. And so therefore they're in these dotted lines here, and they were actually very well protected. So this is kind of, I think, being misinterpreted in the media by saying that natural immunity protects you better than vaccinations in the time of Delta, when actually they should be saying, you know, if you're not vaccinated and you've never had an infection with COVID before, you're kind of screwed. I mean, that's basically what this takeaway should be. But instead, people are hyper focusing on these little lines down at the bottom and ignoring this huge mountain of non-vaccinated people that could have totally avoided Delta infections. And that's what the headlines are focusing on. So just to show you that this is what the actual data shows. I've included some links for you that kind of go through the explanation of this information. And in terms of, you know, what's also interesting is the people that had prior infections actually had a little bit lower case rate than the people that had vaccinations. And so people were like, well, does that mean that prior infection is superior to vaccination as a protection factor? And I think A, the sample size is super small, and B, the CDC has already said, you know what, we don't know why this is happening. This is just the information that we have. But the bottom line is, you know, this is not an argument for everybody should get the infection and get natural immunity, because if you use that strategy, then you're going to have a ton of people that pay the price of being hospitalized or dying on the way to herd immunity. All right, let me stop there and see if there's any questions or commentary. Yeah, I like this quote. It's from a CDC person, I think. The totality of the evidence suggests that both vaccination and having survived COVID each provide protection against subsequent infection and hospitalization. Either of those provides protection, and only one of those is the safe choice that we would recommend, and that's vaccination. So I thought that that was a nice quote. All right, let me move forward to just describe what's going on with the surge. And I know I see Dan Lynch on here, so I may call on him just to help flesh out some of these plans and insights. But basically, we wanted to put together an advisory. So this is a draft of the advisory about what's going on with the surge, so that people, hopefully all of our medical providers are on the same page. And how can we all work together as a network to help with this surge? Because it turns out it's really not just the hospitals that need to be responding at this time. It's really every single medical provider in the county. So what is the current situation? I hope you can see case rates and case positivity reflect an intense upward trend. Hospitalizations are still rising, and they're projected to double. At the time I wrote this, we were in the 400s. Now we're above 500, and they're probably going to go into the 800s, like I said. And this is going to be similar to last winter surge. In fact, it may actually be a little bit higher than last winter surge. Available therapies are extremely limited, and I'll talk more about that in the next page. And testing capacity is not able to meet the demands and clinical needs. And that's something that all of you are experiencing right now. So what is the county doing to build capacity? So we've got calls out for increased staffing to the state. And we've had those for many months. But these calls are staffing to help really relieve our ambulance traffic and get them back into service. So we know that some of our hospitals are really trying to get those kinds of teams into our emergency departments, so that we're not keeping our ambulances waiting for a long time, because that really impacts the level of care that they can provide, and that we're not overtaxing the emergency department personnel who are busy doing other things. PPE has become an issue, so we've asked them to order significant amounts of PPE. And if you need help with PPE, let us know. Contact the Mohawk. Testing kits for home testing have been distributed. So we actually had a program that was so successful that we actually gave away all the testing kits that came in. Like basically they were spoken for within hours with the website that we had set up. And those went out to higher risk zip codes, community-based organizations serving vulnerable populations, and employees of the restaurant industry, knowing that they're pretty high risk essential workers. Clinical providers can continue to request tests. As you can imagine, that pipeline has really narrowed down, and we'll try to fulfill your requests as much as possible. But that's something that everyone is requesting right now. And then there's a federal website. Hopefully you've heard about it. It was pretty well covered in the general media, but these are basically the kits from the federal government. They're going to send 4 kits to every household, regardless of zip code. So any of your patients and you yourself and your staff can sign up for that program. And then the kits will arrive hopefully in the next 1 to 2 weeks for home use. Okay, how can all medical providers help? There's really no easy answers in taking care of large numbers of additional patients. I mean, I hope that that's kind of, self-evident. But we want to share ideas, and we want to hear from you about how we can all help and build best practices during this time of extreme surge. So, I think that for primary care and ambulatory care practices, really think about limiting resource utilization and workups that might trigger hospitalizations. Offer telemedicine and telephone follow-ups for mild or ambulatory COVID cases. And please, please do not send patients to the emergency departments because the emergency departments are just overflowing unless they're critically ill. See if you can actually help out and either see the patient or call the patient or do something to help take care of them without sending them into the ED. Urgent cares, similar kind of strategies. If urgent cares and FQHCs and related ambulatory care practices can expand hours, that would actually help a lot also, because it turns out that, you know, a lot of people seek out emergency department care after hours and on weekends. So really just expanding hours and availability for minor complaints might help. And then we know that a lot of our urgent care and ambulatory care partners are doing monoclonal antibody treatments. Thank you so much for doing that. Please continue to do that, and continue to provide those. Those are actually helping keep people out of the hospital. Skilled nursing facilities, you know, they get a lot of support. They have their own call, but for those of you that work with skilled nursing facilities, please make sure that you're able to support them as best as possible. Tighten up infection control, booster vaccinations for both COVID and influenza, get rapid testing, do make sure that your PPE is accounted for, make sure that you're following the AFLs that are designed for your visitation policies, and get medical consultation before you transfer patients, again, to offload anything that we can from the emergency departments and the hospitals. So if the medical director is able to do the workup and start therapy, or you know, somehow buy a little bit of time so that we can keep patients out of the ER right now who don't need to be there, that would help tremendously. We can even have ambulances go out there if you need help, you know, just having some pre-hospital personnel just take a look at the patient, do vital signs, or help out in some other way. And then home health nursing can actually help too, with providing infusions, for example, wound care, and other basic procedures that may not require emergency department transport. Really think outside the box and see what you can do without overloading the critically overloaded hospitals and emergency departments right now. There's other suggestions for behavioral health. Again, you know, there's a lot of prevention and maintenance care that could prevent mental health emergencies from precipitating emergency department visits, including refilling medications, giving longer prescriptions if it seems safe, so that the patients don't have to go in for refills as much, either to the emergency departments or to your own clinics, and then extending hours and doing telemedicine. Again, I think that there are ways to leverage some of the technology that we have, so that we can again keep our patients safe, but then also use that technology to offload unnecessary visits during this time. And then, you know, we basically continue to struggle with finding places to put inpatient psychiatric patients. And I think that more could be done to see if there's capacity in some of our psychiatric spaces to offload some of those inpatient psych holds that end up clogging the emergency departments in the hospitals. Again, we're just trying to brainstorm about, you know, all the different ways that we can help move resources around in the system. And those of you that work in these organizations, you know, I don't mean to be presumptive at all. You know them better than I do, but please think outside the box and try to be creative, and reach out to us about how we can help support you, because we want people to, you know, take good care of their patients, but also be very mindful that the resources that we are overusing are completely strained, and we really do need to offset the emergency department utilization right now. Emergency departments, we've got the assess and refer policy that we described last week for our EMS. They're also doing assess and refer on site so that they can quickly triage and streamline their volumes. They're also reconsidering admission criteria and considering home health services in some facilities. So I think those are all good practices. And then there's, like I said, kind of a perennial request for additional staff to help with all of the staff shortages that our hospitals are experiencing. Hospitals, we continue to dialogue with the hospitals. I know David Bacci is on with the Hospital Association, and this is something that you know, we continue to brainstorm about how we can support our inpatient services by postponing elective procedures, for example, adding staffing requests, and trying to change the staffing ratios if possible, and other solutions to help during this time of extreme crisis. The last thing that we're really trying to actively explore is whether it makes sense to set up alternative care sites sometimes known as field hospitals. So we're at a point where it would actually help to have one of those. But the problem is, the staffing that it takes to set those up would actually be better used to plug all the staffing shortages at all of the hospitals. So that's the balance that has to be struck, is we don't want to take away staffing resources from hospitals at a time when they are needed there to set up an alternative care site that may or may not be utilized. I mean, we set up alternative care sites during the last winter surge, or even before that, at places like Porterville and at the convention center, and they were really vastly underutilized. And so that becomes the challenge, is making sure that we match the demand with the supply with the rational utilization. And alternative care sites right now are kind of on the back burner because we really need to plug all of the staffing shortages that the hospitals are telling us that they have. Any questions about that? I'll just review the chat really quickly. All right. Yeah, so I see there's some chat about, how to get testing kits, et cetera. So thank you so much for those of you that are able to help your colleagues with information or resources. And remember, we'd love to hear about your shortages with our Mohawk, because the Mohawk is really the best way that the county has to elevate your requests to the state and try to get you things like testing kits. And so remember to use that Mohawk email for any supply needs, whether that's PPE or testing kits for staff. All right, therapeutics updates. So Dr. Zweifler has put out another advisory for the monoclonal antibodies. This one really focuses on sotrovimab, which is very limited, but it's the one that really works with the Omicron variant. Remdesivir is also recommended. It's required as a 3-day infusion. And we know that some of our sites are very strongly considering doing that. So thank you for those of you that are doing some extra homework to get that online. We really appreciate that, and we'll continue to update our monoclonal advisory to help reflect the fact that sotrovimab and remdesivir are really the two medications that we should be considering for treatment of outpatient patients with COVID. In terms of the orals, oh man, I wish I had good news. We were just told that we don't have any allocations coming in this week. So this is basically a 2-week allocation cycle is what the state is kind of settling on right now. So the next allocation will come next week. I'm not optimistic that they will send us very many. They typically send us about 200 doses of Paxlovid and around 800 to 1,000 doses of molnupiravir. At least that's what they did the first couple of times. And that's kind of what we're expecting next week, but we really haven't even seen any raw numbers. We know that it's very confusing because there's so many pharmacies that could potentially have the medication, but when you actually call around to check, it seems like no one has it. And so it leads to a lot of frustration. I hear you, and I wish that I had a way to actually check the inventory of every single pharmacy that's receiving these. We unfortunately don't have that. The state is not giving us access to that inventory system right now. They're saying that, just wait a few more weeks and we'll give you access to it if you're a health department. So right now, even the health departments don't know how many of these pills are on the shelves right now. What we can do is basically limit which pharmacies get these medications. That's really all we're allowed to do. And so that's basically what we have decided to do, is we're going to limit the number of pharmacies to 2 locations. And we think that these are the 2 locations that it's going to be, but don't quote me on this because it's not finalized, but it's basically going to be pharmacies that are, well-placed geographically, but it will really narrow down the options for where you need to send patients. And you won't need to call around to 10 different pharmacies to figure out who's got what medications, et cetera. And so we think that that might be one solution to this really frustrating and confusing process related to distribution. Now, you might have heard and you might have seen that around the state, some hospitals and clinics are also getting doses. And we've heard from you that if you're at a hospital or a clinic that you're really interested in receiving some doses on your own, that you can turn around and hand out to your patients. Obviously, we would love that also. I think that that would be really efficient and great to do. The barrier to doing that right now, again, is the state. They're not allowing us to name any other partners in our county that can actually receive these medications to then give to patients. They basically selected these pharmacies, and that's what they're going with, and they're not allowing us to add to that list right now. It will change. They've already said that they are going to open up the registration site, as it were, for this inventory system called HPOP, and then you can add in, your hospital pharmacy, for example, or if you have a clinic and you're able to and you want to start giving out these medications, you will be able to do it. It's just we have to wait for the state to say, okay, now we're allowing this registration to open up, and then they'll be able to add you as a provider. So that's what's going on with the orals. I know it's super frustrating right now. I wish it was a different situation, but unfortunately, that's the reality of what's happening. With Evusheld, this is a prophylactic injectable medication. We've gotten about 270 doses sent to us in the current allocation. They actually go to two different hospitals, CRMC and St. Agnes, and then those two hospitals actually redistribute to outpatient partners, and that's actually working pretty well. So that basically is allowing us to broaden the network of administering providers in the same way that we have with the monoclonal antibodies. If you want to become an administrating provider for Evusheld, which again, it's an injectable, you give it to immunocompromised patients, and it actually is active for up to 6 months. So it seems like a really good way to protect our very vulnerable immunocompromised population. So we really need to be using this wisely and quickly to get that population protected. And so we would love to have your help if you're interested in providing Evusheld, or if you just want to refer patients because you have a big pool of immunocompromised patients. We really want to hear from you there too, so that we can make sure that you have good, reliable information about where to send your patients. And we're going to be generating, kind of like the advisory for monoclonals, we're going to be generating a list of providers that provide Evusheld, and they will basically be able to accommodate those immunocompromised patients and start giving them the medication. So that's the plan for Evusheld. There's some medications that should not be used, but unfortunately they are being used in our community and throughout the US. And that includes just unproven treatments like ivermectin, outpatient steroids. There may be other treatments that I'm not listing here. I don't want to point fingers and tell you how to practice medicine, but if you're going, into this area, please be very careful. This is medical legally kind of fraught territory. I know that you may be pressured into giving these kinds of medications by patients that are really anxious or are reading the wrong websites, et cetera. But it's really a disservice because, those patients end up having complications that are then having to be managed by our colleagues. And that's how I'm hearing about this is, our inpatient colleagues are seeing people that fail ivermectin, fail outpatient steroids, and they weren't referred to get things like monoclonals or other medications. And then basically you've set that person up for failure. So it's just, it compounds, an already tragic situation into one that kind of just goes into, the territory of just risky medicine. And I want you to practice safe medicine and evidence-based medicine. So I just put that in there that, please don't do these unproven treatments, regardless of what your patients are pressuring you to do. All right, that's really all I have for just in terms of updates. I have some other links for you to read in your spare time that I'll share out whenever we share out these notes. That's really all I have in terms of my formal remarks. Let me see what Naomi says in the chat. We have patients requesting for COVID vaccines after infection. Last week, it was said that once they're healthy, they can get the booster. But does that apply to the initial doses of COVID vaccines as well? Yeah, it actually does. There's really not, they are going to be quote unquote immune, as the CDC paper showed, for a while, just based on the antibodies that their own body generated as a result of surviving COVID. And so they don't have to get COVID vaccines right away. They can wait up to 90 days. But if they want to, as soon as they're better, then they can go ahead and go get either a vaccine or a booster. And there's really no physiologic reason why they can't get their vaccine as soon as that they're well. All right, let me pause there and see if there's anyone who wants to ask any questions or share any remarks.
I was wondering if I could ask a question. So I know that you shared that there's less people that have been boosted that are getting hospitalized and dying, which is kind of the same as we see for flu shots type of thing. Do we have any idea how many people with boosters are still getting it? Because I'm in your boat and I have it and I've been coughing for 2 weeks.
God bless you. Yeah, no, the number of breakthrough infections with COVID is really high, even in the boosted population. I don't have a percent or any hard numbers for you, but anecdotally, it's really just working its way through even the boosted population. But knock on wood, hopefully we're all staying on the mild end of the spectrum. And so that's why, I think what this surge is really teaching is, I think, just a recalibration of the expectations around the vaccines, and really, for what it's worth, because these vaccines were not designed to go against this new variant, they're really not going to keep us from getting infected, as we both have learned through painful experience, Kelly. But they seem to really slow down the variant, in terms of the damage that it does in the body. And really, I'm experiencing the stuff that the literature reflects, which is that this stuff stays in the upper airway, and it doesn't really work its way down into the lungs. And so it doesn't really land people into that range of pneumonia, hypoxemia, and other systemic complications that then trigger the hospitalization. That this really converts what would otherwise be, a very severe infection into like a viral URI. So I think that's what we're seeing now with the boosters is, people are going to get it, that it's so contagious and so good at infecting that even the booster is not going to keep you from totally fending it off. But your immune system is so ready for it that, just within a few days, your antibodies start fighting it, and it just doesn't have a chance to progress, any lower into the lower airways.
Gotcha.
Wishful thinking, so.
My 5-year-old has still been crawling up in my lap, and she is still.
I know that's the other thing is my kids both had it, and now they're totally back to their normal energy level, and my wife and I are just like still going through the crud, and so it's interesting. And we're obviously very thankful for that. There's the children's hospitals are filling up with kids that are less fortunate, and so for what it's worth, the schools are really, they're very challenged. If you work with the schools, or if you have relatives that are working in the schools, they'll tell you that this is just a really challenging time for them as well, and they're doing the best that they can at keeping kids in school with the safe procedures that they have in place. And although we've had to close a few classrooms, Dr. Zweifler tells me that we haven't had to mandate closing any schools per se, unlike other jurisdictions. Like, you've heard about Northern and Southern California, and I think even Kern County, where entire schools have had to be closed, mainly due to staff shortages, which, knock on wood, we haven't had yet. But again, it's one of those things that it's hard to be overconfident because we still have so many more weeks left for this surge. Good question. So the question is, do we know when under 5 will be eligible for vaccination? And I just saw on an article this morning that Dr. Fauci was quoted as predicting maybe in the next month, just depending on what the FDA decides, they will actually review the data. And then, they're saying probably in the order of weeks that the FDA will grant an EUA for the under 5 population to get vaccinated, which I think would be welcome news by a lot of parents. Does a recent COVID infection have any influence on the February 1st due date for HCP boosters? Yeah, that's a good question, because those are folks that are considered booster eligible. And what you're asking is, does a recent COVID infection affect booster eligibility? I'd have to look that up. That's actually a good question. I don't know off the top of my head because I don't remember reading that in the CDPH booster mandate that they put out. So we'll have to get back to you on that one. But I would just refer you to that CDPH booster guideline that they put out to see if there's a clause in there for those that have had a recent COVID infection, whether they can delay getting their boosters past the February 1st deadline, because presumably they've got another window of immunity as a result of their infection. Does anybody else know, or has anybody else had to address that issue?
I was told down in Kern County that no, they still needed to get their booster once they, had recovered enough to get it. We had one case though that they'd gotten monoclonal antibodies, so they're not really eligible for it. So they're not eligible, so they don't have to get it, but whether or not to test them, especially because Delta doesn't confer immunity for Omicron. So nobody really had a good.
Yeah, that's interesting because I forgot that. I remember that monoclonal antibodies are another reason to postpone vaccination, and I remember having to deal with that very early on when vaccines were first introduced. It's not something that we talk about every day. But what I was going to say is, these are not the folks that are going to be your high-risk staff. If they've survived COVID, then presumably they're not going to be the ones that are at risk of catching it or passing it on once they've waited their period of isolation. So for what it's worth, even though the letter of the law says one thing, just from an infection control perspective, thankfully that they did survive without having any severe complications. And once they come back to work, they're really not the ones that are going to be a risk for, outbreaks and things like that. Okay, so I see here in the chat, thank you all. Thanks, Colleen and David. The AFL doesn't have an exemption for recent infections for the booster, so they're still on the hook for the February 1st date. And then the MABs would be a reason to grant a temporary medical exemption and still be in compliance. So remember, you can do temporary exemptions for people that need a postponement, either related to a medical condition, or in this case for the monoclonal antibodies. Thank you. That was very helpful, David. And then Rick is asking what the dose for the under 5-year-old will be. I haven't read what that would be, so I'm still waiting to hear, exactly. I imagine it'll be lower than the adult dose. I don't know if it'll be the same as the dose that they're giving to the older kids. Good question. And I think it's probably going to be Pfizer first, because Pfizer's kind of been ahead of the pack with all of these trials and studies and stuff like that, with Moderna following closely thereafter. Thanks, Rick. All righty. Any other questions or comments? All right, well, we'll continue to work and support all of you as best as we can. Please be in touch with us. Like I said, use the Mohawk email for any resource requests that you have. Reach out to myself or any of my team for any information requests. And as we get updates as we get more information about more ways that we can support the pandemic response, we will definitely share them out with you. And May is asking, when will we be allocated more monoclonal antibodies to our county? So that schedule has not really been disrupted as far as I know. And there are weekly allocations set up for that, May. And the sotrovimab, like I said, they've been giving us around 200 doses of sotrovimab. It was 90 the week last week, and it was about 170 this week. So we're hoping that it's in that range again next week. We know that you're using it up, so we really appreciate that. Like I said, we may have some remdesivir sites coming online soon, which will be great. But as far as I know, that allocation is continuing week after week. And Curtis Jack, it can help answer any questions about how to request yours. And we even got some from Mariposa County because they didn't need as many as they got allocated. So thank you to our friends in Mariposa County. They gave us 6 vials that they weren't using. All right, if there's no other comments, thank you all so much. I really appreciate your support. I'm wishing you the best of health, and I hope to be feeling better next week so I can talk your ear off for a whole hour instead of just 45 minutes. Thank you so much. Take care. Bye.
Thank you.